Go on, doctor. Sorry. Hello?
Yes, sir.
Yes, go on. Go
I'm
on.
with you.
Yeah, go on.
Yes, sir. In the right axilla, I can appreciate there are few and eye lymph nodes. These skin lesions, I can give differentials in this case. These could be some neurofibromas or other skin tags. The nipple is looking normal. Skin is also normal except for in retroareolar region. It could be projectional. Uh, so I will inform the findings to the referring physician and also will suggest ultrasound correlation and also for systemic review to rule out any history of workup for neurofibromas and also will yeah
Yes.
also ultrasound correlation will be helpful in this case.
Okay. Okay. Anything else do you want to do?
Yeah, ultrasound. First of all, I will do the ultrasound and will, as these are purely skin lesions, skin related lesions. So first, it needs a further workup. Other for neurofibromatosis, other differentials include skin. I think I need ultrasound if there is available for
Thank you,
further
doctor, so
confirmation.
much. Thank you so much, doctor. It is a case of neurofibromatosis. Okay. Case of neurofibromatosis. Look, 1, 2, 3, 1, 2, like this. And she described very well in the axial. Okay. From the craniopodal, she depicates this is a skin lesion. Thank you, doctor, so much. Next
Thank
candidate.
you, sir.
Welcome. Next candidate.
Yes, hi, doctor.
Request control. 85-year-old female patient with low glaucoma scale. Go on. No, leave. 1 second. 1 second. Use the arrow.
Sorry, sir, I can't scroll.
Okay. Leave.
Okay, so I'm presented with axial CT brain cuts without contrast for 85 years female, presented with low glaucoma scale. I will check my sequences from up to bottom, and then I will give my command. I can see that the patient is intubated. Okay. Cerebellum looks fine. I can see that there's age-appropriate involutional brain changes. There's bilateral hypodensity surrounding the ventricles, in keeping with ischemic microvascular ischemic changes, chronic ischemic changes.
Mm-hmm.
Yeah, I'm trying to look if there's.
What do you need next?
I would like to check in the other sequences, coronal and sagittal, to make sure if there's any other findings.
See, this is post-contrast.
Okay.
Or arterial. This is arterial.
Okay.
Arterial phase angiography.
Okay. The bilateral ACA appear normal. The MCAs also seem fine. Okay. This can't see the passenger. This is vertical, posterior. Okay. Can you go further down?
No. Look at this slice. Well, what happened?
This is a basilar artery, and there is left branching artery seen in front of bones. Yeah.
Look again, doctor. Don't worry about the basilar. The basilar is good. What's else?
This is a superior cerebral artery.
Doctor, what
Cerebellar,
is
sorry.
this? What is this? What is
This
it?
is the internal. This is the internal carotid artery. On the
Okay.
on the left side appear normal. On the right side is not visualized, thrombosed.
Okay.
Okay. Yeah, it's still. So, okay, so there was a thrombosis of the internal carotid artery on the right side.
Okay.
Down. Okay, is there a pulmonary embolism as well on both on the left side and on the right side?
Excellent.
Okay, there is multiple bilateral pulmonary embolism and thrombosis of the right internal carotid artery.
Excellent.
So yes. So in my routine practice, I would like to check the lung windows to make sure that there's.
Don't worry about it. Give me your final diagnosis, please.
Can I check the internal jugular vein? Sorry, on the other side.
Don't worry about it. Don't
The
worry
vein. Okay.
about it. Don't worry.
Okay, so now my finding is bilateral pulmonary embolism and thrombosis of the right internal carotid artery.
What else? See, what is this?
This is the vertebral. This is the vertebral on the left side is well seen, and also thrombosis of the vertebral on the right side.
Excellent. So, give me your final diagnosis, please. What is your final diagnosis and management?
I can see that the patient had bilateral right internal and vertebral artery thrombosis, arterial thrombosis with
So not
pulmonary.
bilateral. So doctor, not bilateral. Right-sided.
Right-sided, yeah.
Okay.
So the patient might have AVMs causing thrombosis.
How come, doctor? Doctor, no. Don't tell like this. What about this? From the beginning, you will. Yeah, this is almost the source. This is the source.
Pulmonary embolism. Yes, yeah. Okay. This is pulmonary embolism and causing complicated by thrombosis in the right internal carotid and right vertebral artery.
What's your next step? Management. Talk about management.
My management. I will convey my finding to the referral physician to start anticoagulant treatment, and I would like to also notify the stroke unit.
And what about the interventional?
Stroke unit and discuss with the intervention radiology team.
Thank you, doctor, so much. See, my friends. See, the trick is the age of the film. See here, here, very tricky, and even here, from the beginning. See, look, it's not well seen. See, if you look here at the right side, there are hyperdensity in the right ICA, in the post contrast or in the arterial angiography. This is arterial. See here, very clear. So skull base and intracranial vessels one of the most important review areas in the brain study, either CT or MRI. Very critical. Why? If she can't pick up this one, she will lose all the case. And compare. When you compare, your eye alert your brain. Oh, there are a difference. There are discrepancy. Okay? See, my colleagues? Complete thrombosis of the right ICA. Then when we look down, and this is one of the very nice film for age film, and being and showing all the slices. You go down. There are some distinction here, okay, but some distinction, no problem, not a big deal. But if you go down, down, you will find the pulmonary embolism. See, my colleagues, if you miss this multiple pulmonary embolism, you will lose this case at all. Why? Because it is a life-saving. Thank you, doctor, so much.
Thank you.
Next candidate, request control, please. Hello?
Hello, sir.
Request control, please.
Sorry, I don't have control, but I'm number 9 and I cannot
No
see
problem.
number 8. Okay.
No problem.
Okay.
This patient has ankle pain.
I have been presented with the MRI surgical sequence for another patient with history of ankle pain. I will go through my images and then I'll come back to my finding. I can see that there is abnormality noticed within the talus bone, more specifically within the apex of the talus bone. I can see that the joint space between the distal tibia and the talus bone is preserved. I cannot see any joint fusion. I can see that the rest of the talus bone showed normal bone marrow character, and the rest of the tarsal bone appears within normal. In my routine practice, I want to check the rest of this sequence and projections.
What's your differential, doctor? See, you
First
describe
of all,
you describe
Yeah.
something, okay? And
Yeah.
especially in MSK, it is not related to the surrounding. You find something in the talus, okay? So after describing, give me a differential and then go through the rest of the exam. What's your
Okay.
differential?
The differential diagnosis, this is first I'm thinking about avascular necrosis within the talus bone. Yes.
What is the name of
Here.
this sign, though? What is the name of this?
I don't remember the name of the sign actually, but I can
What is
see
this?
that there is
This line.
Yeah.
This line. How can you describe this line?
This is a well circumscribed sclerotic.
No, not well circumscribed. In avascular necrosis, the line has a specific name and has a specific shape. Is this straight or serpentinous?
No, serpentinous, yes.
Subcortical or intramedullary?
In this case, I can see that it is subcortical rather than intramedullary.
Double line sign or not double line sign?
Double line sign.
So all this password, my colleagues, is very important. It is very clear. See, this is a sclerotic band and this is non-sclerotic or granulation tissue. So this is a double line sign. Subcortical, serpentinous. 3 password here, very important. Okay. What is the difference, doctor, in your opinion, between avascular necrosis and medullary infarction or bone infarction? from a
The
radiological
difference, one,
point of view.
I think vascular necrosis occurs in specific locations such as the head of the femur bone and such as this case
What
within the
else?
talus bone.
What else?
The bone infarction is intramedullary rather than subcortical, and I think
Excellent.
the
Excellent.
subcortical.
Stop here. Stop here. This is the point. This is the answer. The bone infarction within the bone marrow, but the vascular necrosis is subcortical. Okay. Some textbook said that vascular necrosis start at the beginning as insufficiency fraction. Okay, and then proceed to vascular necrosis. Okay, next candidate.
Okay. I think number 10.
Next
Assalamu alaikum,
candidate.
sir.
Oh, sorry. Give me 1 second, my colleague. 1 second. Sorry, my colleagues. Next candidate.
Yes, sir.
Request control, please.
Okay, sir. So I have requested.
55-year-old female patient has a
Okay, sir.
chronic illness. Okay.
Okay, sir.
Go on.
Okay, this is CT brain plane sections, axial sections, and which I will go from top to bottom. And in the first striking abnormality that I can see that there are multiple rounded lesions having variable sizes and densities noted involving the brain, the suprasellar region, and also some of them are noted in the infratentorial region and supratentorial region also.
Okay.
They are surrounded by intense vasogenic edema.
Excellent.
Some of them are showing a peripheral hyperdense periphery, and some of them are showing a few
Excellent.
foci of calcium as well.
Few
So
foci of
keeping in
what?
view
What?
the
Again. Few foci of what?
hyperdensity, there can be
Yes.
calcification, but
Okay. But better to
Okay,
set
sir.
hyperdensity. Okay.
Okay, sir. Keeping in view the radiological findings, and these are also causing mild mass effect on the ventricular system and also on the adjacent brain parenchyma. So keeping in view the radiological findings up till this, I will like to give the differentials of metastatic disease process versus some infective etiology such as abscesses, but I would like to see it on post-contrast images, and also would compare the read the notes, surgical notes or any other notes of the patient to see if there is any history of primary bone tumor, primary tumor that can lead to mets. So this is the post-contrast images, and here I can see that there is mild meningeal enhancement also, and almost all the lesions are showing peripheral enhancement. Along with the vasogenic edema. There is also some of them are abutting the cortex of the bone. So I will also see the bone window to see if there is any involvement.
You are brilliant.
So it is.
Go on.
Yes. Thank you, sir. So it is. So this is the bone window. Okay. bone window. This is showing some there is evidence of some sclerotic lesions in the bone as well, patchy areas of increased sclerosis. So keeping in view the radiological findings, I would like to keep the differential of metastatic disease process on the top of the differentials, and would want to know about the history of the primary. If there is any primary, I would tell the patients to the referring physician, and would further want to see if there is any
Which
MRI of the patient.
primary do you think about?
Sir, if it's a female patient, it can be breast.
Okay.
CA, because sclerotic bone mets and also intracerebral mets.
What's your next step?
MRI.
MRI. What else?
So search for the primary and review of do whole CT cap post contrast CT of chest, abdomen, pelvis to look for any primary.
Could you give CC 1 second? Give me a simple radiological examination.
So for this specific, I would like to go for MRI brain.
You told me she is a female. I suspect the primary is a breast cancer. So what's your next step?
Ultrasound breast or mammography, whichever is
very
available.
Easy. Very easy. Okay. Very easy.
Okay,
then you will do staging CT scan or PET CT. But my colleagues, take care from this very minor mistakes. Why? Because in UK, the NHS is a governmental. Number one, they want to save money. This is very logic. And this, second, this patient, if you ask for MRI, she will at least very long waiting list. Okay. So try to use the most simple available radiological examination. Okay. Thank you, doctor, so much. My colleagues, it is very obvious case. Leave the house, please. It is very obvious case of cystic metastasis of the brain. Okay. Like you said here, see, this is not a benign cyst. Why? Nodular peripheral enhancement. Okay, my colleagues, very clear, nodular peripheral enhancement. Then the doctor did very well when she asked for bone window. Thank you so much. If you are talking about this calcification, okay, in the right side, yes. Okay, thank you, doctor. Next candidate.
Yes, sir. Hello.
Hello. Ask control, please.
Yes, sir. Hello.
We did it. We did this one or no? A second. No, we didn't. Okay. Control.
Okay. So I'm presented with 13 years old female patient. Incidental finding on ultrasound exam performed for the urinary tract infection.
Okay. Scroll.
Okay. I'm presented with MRI pelvis or sagittal sections, T2 weighted images of a female patient, in which I can see that there is marked a distension of the urinary bladder, and the uterus appears unremarkable. The urinary bladder is distended, reaching up to the level of umbilicus. I am looking at the bones. The visualized part of the lumbar and sacral elements appears unremarkable. No osseous bony abnormality seen at this level. However, I want to see the neural canal, spinal canal. As it's a very distended bladder, so it could be due to any neurogenic bladder. And I will also like to see the kidneys, bilateral kidneys as well, to look for any hydronephrosis or renal abnormality.
Okay.
Can you see the axial sections?
This is axial, axial or prone. This is axial.
Okay. Yeah. Okay. So all right. So I can see on the axial sections that there are two uterine horns with separate endometrial canal and two separate myometriums,
Excellent.
raising concern for uterine didelphys.
Okay.
There are two cervical canals as well. Um,
So,
However, I do not see any evidence of hematometrocolpos or any obstruction.
okay.
Yes, and this urinary bladder is distended.
So, what's your differential diagnosis?
As the patient has uterine didelphys, so it is sometimes associated with the renal anomalies as well. And keeping
Excellent.
in view the distended bladder, I want to look at the bilateral kidneys to look for the
Excellent.
status of any renal anomaly.
Thank you, doctor, so much. This is the point. Yeah, that you should do something for the kidneys. Almost ultrasound. This is a case of didelphys, and you can pick up it from the sagittal. It is difficult,
Yes,
but if the
yes, I
examiner,
want to. So yes,
yes,
ultrasound.
yes, thank you, doctor.
Yeah,
See, from the sagittal, see,
thank you.
one horn smaller than the other horn. See here. This is the uterus. Then it become very small. Then what is this? See, one horn, then cervix, and another cervix, then the second horn. Okay. Here you can use also
Yes.
the coronal. This is your right to ask really for axial and coronal, but I'm showing you how to detect from the sagittal. Next step is to do ultrasound of both kidneys. Thank you, doctor, so much. Next candidate.
Assalamu alaikum, sir.
Thank you.
Welcome. 55 request control. 55-year-old male patient complaining of knee pain. Go on.
Sir, I've been presented with the axial FRCR T2 images of a 55-year-old patient presenting with the knee pain. The first thing abnormality I noted is actually the hyperdense, the high signal area that is seen bilaterally, more so on the left side along the retinaculum, bilateral retinacula.
Where? Where?
Sorry, sir. This in the
This muscle.
the,
This is muscle.
this
Don't worry about it.
the high signals in the muscle. Okay.
No, this is a normal muscle. This is, or sorry, 1 second.
There is
a
this.
muscle. This is a muscle. This is the
Okay.
quadriceps. Okay, don't worry about it. Go on.
Further, there is effusion noted. Sir, you're scrolling or I'm scrolling?
You. Go on.
Sir, effusion is seen.
What else?
Sir, apart from this, this bilateral menisci appears grossly okay.
Okay.
I would like to see the anterior and the posterior cruciate ligament on the lateral views. Sir, this
lateral view? We didn't have
yes,
lateral
sir.
view. We didn't have lateral.
Sagittal, sorry.
Sagittal, okay. Yeah, go on.
Okay, so I'm not able to mucoid degeneration of the lateral meniscus is seen. Apart from this, there is high signal. High signal is seen in within the anterior cruciate ligament, within the fibers of the
Don't worry
ACL.
about it. No, don't worry about it.
How it appears intact, and PCL is also intact. So there is mucoid degeneration of the posterior horn of the medial meniscus.
Okay, what else? Leave the mouse. Leave. Look at the coronal vein.
Yes. Okay. Sorry. Sir, the lateral meniscus appears to be extending.
Don't
Sir,
worry about it. Don't worry.
quite-
Stop here. Stop. No. Go back. No. Look here. What happened?
Sir, there is high signal along the posterior root of the medial meniscus.
Excellent. So what's your
Posterior
diagnosis?
root yes.
What's your diagnosis?
Sir, posterior root avulsion or posterior root tear of the medial horn of the
Excellent.
posterior horn of the medial meniscus.
Excellent. See, my colleagues, this is the root. What happened? Compare with the lateral meniscus. Here,
Yes.
complete dark signal. Here, bright signal. Also here. See? Posterior to the root, there are high signal. Also in the axial. The root here is truncated by high signal. Thank you, doctor, so much. This is medial meniscus root injury. Next candidate, request control, please.
Sir, I'm on phone. Please, can you scroll for me?
Yes.
Hello?
65-year-old, yes. 65-year-old female patient presented with abdominal pain.
Okay, sir. I'm provided with CT scan abdominal images. I would like to have a look at the whole of the stack before commenting on. Sir, I'm provided with the images, and I could appreciate first obvious abnormality. I could appreciate is mild abdominal free fluid. The liver, the abdominal viscera are grossly fine. In the lower abdomen, I could appreciate that there is diffuse thickening of bowel loops. I think these are the I want to confirm that these are smaller large bowel loop. In addition to that, I could appreciate an intensely enhancing mesenteric mass with surrounding speculations radiating towards the surrounding mesentery. Sir, I want to look at the. Want to have a look at the ileum in the appendix. The terminal. So, sir, I could think that the terminal ileocecal junction is fine. I'm not able to look at the appendix right now.
Doctor, see.
In addition to that, I could appreciate a small hernia with the.
Yeah, doctor, listen to me.
Yes,
you
sir.
find two major pathology. Don't shift from them.
Yes, sir.
First, give me a full details. You talk about this,
Sir,
and you talk about this. So
yeah,
first, stop
yes,
at
sir.
them. Talk about them
Okay,
in
sir.
full details.
Sir, I'm thinking of a mesenteric carcinoid deposit
Okay.
with teething of adjacent bowel loop.
Okay.
As it
What
is an
else?
intensely
Why?
enhancing mass.
Okay. Why is this bowel loop is second? Look here. What happened? See, look at this bowel loop and compare with the normal bowel loop here. What is the difference?
Yes. So the bowel is thickened, edematous, and hypoenhancing.
So what do you think?
And dilated as well. Sir, I'm thinking that maybe this carcinoid is causing compression of the vessels and there is resultant ischemia of the bowel.
Yeah.
Or there may be
possible. Did you confirm or not confirm this? This confirmed or
sir,
not?
I think on the coronal sequence, I could not. There is the mesenteric vessels are not enhancing well.
No, it is enhancing. See, enhancing. But what happened here?
No, sir. Beyond this mass, the
Yes,
vessels
beyond the
don't
mass.
seem to be
So
enhancing.
what happened? This is the superior mesenteric. Okay, what happened?
Yeah, this mass is causing compression of the superior mesenteric artery, the branches, and resulting
Okay,
in bowel, resulting in bowel.
give
And
me
I
your
want to look at
diagnosis.
the liver. Sir, I'm
Okay,
thinking of carcinoid with the compression of the vessels and resultant ischemia. In my routine practice, I would like to have a look at the liver. Yeah, there is no liver mets noted in the current scan, and the lungs also seem fine. So my primary diagnosis is carcinoid. I would like to do a octreotide or MIPG scan to look for the primary that may be in the ileum or appendix somewhere. I would like to convey my findings to the surgeon and take a surgery consult and neuroendocrine consult as well.
thank you, doctor, so much. Doctor, what is the difference between
Thank
between when you find a metastasis in the liver? Okay, is your diagnosis will it change or not?
Sorry, sir, your voice, I
Again,
wasn't able to hear it. But
what is when you diagnosed? When can you diagnose a carcinoid syndrome?
Sir, yes, when there are liver mets, then the serotonin is not degraded, and the patient has symptoms of flushing and diarrhea, and then we are able to diagnose the carcinoid syndrome.
Thank you, doctor, so
Otherwise,
much.
thank you, sir.
Thank you. Thank you. See, my colleagues, please, one advice when you start, don't speak about, oh, doctor, I'm fine. Some, especially it is very minimal. Okay, very minimal ascites. Liver is normal. No, have a look first. Okay, survey where is the main pathology, here, and please start talking about it. Don't leave a huge disaster like this and then give me some site finding. In the Viva, you may have site finding in the case. I think no time to talk about it at all. Okay. Then talk in full details. Doctor, this is mass, is irregular. Okay. Has surrounded by some lymph nodes, and it has a speculating REMS extending to the bowel, tethering the bowel. Doctor, the bowel is dilated, thickened, and hypoenhancing. I have a big doubt of ischemia. So let me check of the mesenteric vessels. Okay. This is the mesenteric vessel, both of them. Okay, you should follow them, especially this is a small bowel. So you should see, this is the vessels. Look here, my colleagues, down. It is engulfed within the mass. So it is in superior mesenteric ischemia. And as it is second wall, it may be venous. Okay, my colleagues, this is a case of carcinoid tumor associated with mesenteric ischemia. Next candidate.
Yes, doctor. Yes, I'm
request control.
okay.
Ten-year-old. 1 second.
Okay.
10-year-old male patient presented with knee pain. Go on.
Okay. Just 1 second. I've been presented with 10 years old, coming with knee pain. This is MRI sagittal section for T1. I will scroll down to check exactly, and then I will comment on the finding. Okay. While I'm commenting, is there any history of trauma or
no trauma?
Just okay, just knee pain. Okay. I can see that both menisci appearing normal.
Okay, 1 second.
BCL also appearing. Okay.
Look here. Look.
Okay. Okay. In this view, in this sagittal stair T2, I can see that there is evidence of abnormal hyperintensity. Sorry, doc, it's not scrolling. Okay. I can see that there is evidence of mild free fluid signal noted within the joint. Doc,
Okay.
it's not moving. It's not moving. It's not scrolling.
Don't worry about the fluid. What else? What else?
Okay. Okay. I will have a scroll. Okay, I can see that there is abnormal bone marrow signal noted within the metaphysis at the distal femur shaft.
Don't worry about it. What else? See, doctor, the
Okay.
patient is 10-year-old. What is the most common? And he didn't have any history of trauma. What is the most
Oh,
common in this age group? In jumper. He is a jumper.
jumper. Okay. So it could be I'm checking the tibial tuberosity and
What happened?
okay. Blood vessels, the muscles appearing normal.
Leave the mouse. What happened here?
Okay. I couldn't see here.
What happened here?
Within the
Leave the mouse.
sorry. Yeah,
Leave the mouse.
I couldn't see your cursor.
What happened here?
This is a tibial tuberosity and it appears to be slightly fragmented.
So, what are you thinking about?
It's Osgood-Schlatter disease.
Okay, look here.
What?
Look here, see. This signal here
This is
at the
abnormal
tibial,
hyperintensive signal noted within the tibial tuberosity.
tibial tuberosity is of high signal in 10-year-old male patient. Okay, you should think about Osgood-Schlatter syndrome. Thank you so much. My colleagues, take a home message. When you listen the history and before you examine the MRI or CT, put in your mind some expectation. This is a young age, has a knee pain, has no history of trauma. Okay, all of us will see the cruciate, the meniscus. Okay, but in younger age with no history of trauma, think about Osgood-Schlatter syndrome. Okay, my colleagues. Next candidate. Next candidate. Hello.
Assalamu alaikum, sir. Can you hear me?
Salam. Yes. Request control.
Sir, it is difficult. Please.
35-year-old male patient complaining of weakness of both lower limb.
This is MRI T1 fat set axial section in a patient who has complained of acute lower limb pain. In this, I can appreciate that there is diffuse swelling of the cord. There are some heterogeneous internal hyperintense changes within the cord, and they are extending towards from the center to the periphery, sparing some of the anterior part of the cord. I can also appreciate that in left apical lung zone, there is some heterogeneous hyperintense signal with some surrounding speculations. There are few scattered area of hyperintensity also seen in the right apical region. The left hyperintense signals are tracking along the left apico apical and posterior margins. They have a cavitating appearance in the center as well. I can suspect that there are multiple actually cavities. Some of them are coalescents. I'm trying to look for any nodes or sir, is this T1 contrast enhanced?
This
So
is
I
a
believe
contrast.
this is
This is a
okay.
contrast.
So in the contrast enhanced sagittal images fed set in the same patient, I can appreciate that there is a pre and paravertebral soft tissue collection, with soft tissue hyperintensive mass, which is having which is causing some signal abnormality in one of the vertebral region as well. The cord is swollen. There is subligamentous. I'm trying to look for subligamentous spread. Um, I don't. I think there is no subligamentous spread. The intervening disc spaces are normal. There is an enhancing collection seen posterior to the cord in the upper thoracic level. It is showing
Yes,
marginal enhancement. I believe this
yes.
is not phlegmon. This is abscess, and it urgently needs to be communicated to the neurointerventional radiologist. It needs to be drained. The
Mm-hmm.
marrow signal in one of the vertebrae is the extension of the same process. I would next like to look for any evidence of any vascular involvement just to rule out, because this is the area it might involve any major vessels. But this posterior vertebral collection is an intradural abscess, and there are
And
cord signals as well. There's fibrocavitatory changes. So all this looks like a sequelae of pre-existing tuberculous infection, which has now extended as acute acute intradural abscess.
excellent, excellent, excellent. What's your diagnosis for this lung pathology?
Sir, it is acute tuberculous cavity, which has now
Do you
extended.
think, 1 second, do you think if this a tuberculous abscess, it will be this is the appearance? It will give this appearance. Look at the bone.
No, no, bones are spared.
So it is biogenic or tuberculous?
It is pyogenic. It is
Yes.
pyogenic.
It may, يعني, if you told the doctor this is extensive infection, okay, it may be pyogenic rather than tuberculous, okay, it will be acceptable. Especially, see here, there are a large empyema or abscess, and the bone almost healthy, except these bones show some edema only, and there are pre-vertebral abnormal signal. Thank you, doctor, so much. This is a case of necrotizing left apical necrotizing pneumonia, result in empyema and cord swelling, myelitis. I think one examiner may give you this axial only, and from which he want everything from you. Look here carefully, my colleagues. See, there are osteomyelitis here of this joint, costovertebral, and then see, there are some extension here and here bilaterally, and let's see here. This is very obvious. Spread of the infection through the neural foramen, and then cord is swollen. It's very important case. Doctor, you didn't tell me anything about the management. You did everything is excellent except one important thing to tell me about the management. What's your management?
Sir, it needs to be urgently drained
Yes.
under fluoroscopy guidance.
No. This is need spinal laminectomy or need neuro surgical intervention. I think it is how could you drain this fluoroscopy? I'm not expert in intervention, but I think it may need surgery. Okay, thank you, doctor, so much. You did very well. Next candidate.
Thank you, sir.
Next candidate.
I think number 20, or maybe in 18 and 19. I see now 18 and 19.
Okay, anyone ready? Hello? Anyone ready?
18, 19, or 20?
Anyone?
Yes, sir.
Yeah,
Yes,
welcome.
sir.
This is a 1 month request control list. A 1 month female patient presented with right cheek swelling.
Okay, sir. Okay. If it's a ultrasound images of a 1-month-old child with a cheek swelling. Is it parotid gland? His parotid gland is shown and is showing significantly increased vascularity.
Yeah.
So, in a child with a swelling and increased vascularity, first possibility is acute viral parotitis.
What else? The patient didn't have any fever. What else?
Then if the other possibility of parotid swelling, other parotid lesions include some, if the patient has any immunocompromised child, if the HIV infected, if there is a history of HIV infection for the mother or something like that.
What would you do next?
MRI of parotid.
Is there something else I can help with? Oh, 1 second.
Okay, these are the MRI images of the same child. There is evidence of a T2 hyperintense lesion in the right parotid region with the evidence of multiple flow voids inside.
Yes.
I am suspecting a hemangioma in this case.
Excellent.
In a child is a possibility, and there is I will correlate with the clinical history whether the patient has any associated skin changes or nevus.
Okay, what else? Look again. What else?
Okay. The right orbit, there is evidence of some hyperintensity.
So what's your diagnosis?
Edema. Okay, that can. It also, I would like to see. Okay, there is edema and thickening of the preseptal region also. I would like to see the other images also of the orbit.
No need. What's your diagnosis? Very conclusive.
So, in a child, I'm not able to tell. Maybe some. I'm not able to tell.
No. You told the parotid have hemangioma.
It can be hemangioma of the orbit also.
Yeah, excellent. Thank you so much. Please, my colleague, trust in yourself. See, I will give you one advice. The first answer in your brain in any exam, almost it is the most correct answer. Really, I'm not joking. The first answer is you didn't have a better than this. Even if it is not the best answer, I think you didn't have a better answer than it in your brain, unless you see a very obvious sign that make you change your mind. Okay, but when you are confusing, use the first thing coming in your mind. Okay, thank you so much. This is a large mass in the parotid and a much smaller similar mass in the right orbit. Okay, intraorbit, extraquinal. Okay, extraquinal, extraocular. Okay, both of them shows multiple signal void. What coming in your mind? Hemangiomas, hemangioendothelioma, like this. Okay, at least this is a benign tumor. Search for philippoli. Okay, search for signal voids. This is a hemangioma or hemangioendothelioma. Thank you, doctor, so much. You did very well. By the way, hemangioma is a tumor. Okay, but a vascular malformation, not a tumor. vascular malformation is hamartoma, normal tissue in abnormal location. Hemangioma, there are benign type, locally malignant type, and malignant type of hemangiomas. Okay, my colleagues? So hemangioma is a true tumor. Thank you so much. Next candidate.
Sir, I'm candidate number 20.
Welcome. Give me 1
Any
second,
other
please.
candidate?
1 second.
I don't know. Okay, 19 first. You can.
Yes, Doctor. Hi, I'm a candidate 19.
Sorry?
Yes, Doctor, I'm here. Yeah, I'm here. I'm candidate 19, Doctor.
Yes, welcome. Sorry, because I have some urgent calls, so I interrupt you today twice.
No worries, Doctor.
Okay, doctor, this is an 8-month male patient presented with 1 month history of wrist swelling.
Wrist swelling.
Yes.
Okay, I have here radius ulnar and wrist radiograph of a skeletal immature patient.
Yes.
There's no there are no break in cortex to suggest any fracture or any bowing or buckling of the bone.
Yes. What is your next step? What is your next step?
My next step, I think, to ask for a lateral view.
Excellent. This is lateral view.
Okay. So in this lateral view of the radius ulnar, I'm able to appreciate at the distal end.
Yes.
The bony epiphysis appears to be irregular with lytic the intra-articular edges appear lytic sclerotic. However, no bony expansion, and there's also periosteal reaction seen.
Excellent.
Both,
what do you want to do next?
I would like to
What is your next step? In your routine practice, what are you doing in similar case?
I will
tell you. You are zooming.
Oh, okay.
See, my colleagues here, we are talking more about the technique of the exam. And see, zooming is one of the most important requests that the examiner wanted to listen from you, especially in chest. I have one chest X-ray, and I think the examiner give me a good mark because I'm talking about zooming. I will zoom to rule out this, despite the pathology were something elsewhere. I was very away from the pathology, but he liked the technique. We will zoom in our routine practice. We will zoom. After zooming, you will find something. Correct?
Yes. Yes.
Okay.
Yes. Yes, Doctor. So, okay, in this lateral view, I'm able to appreciate the epiphysis of the radial bone appears to be depressed with lytic at its articular aspect.
So tell me, this is aggressive or benign process?
It looks, although it has periosteal reaction, but it looks somewhat benign because I can see there's a narrow.
What do you want to do next? What do you want to do?
Maybe I'm worried of still infection.
Yes. What do you want to do?
Probably a MRI.
Yes. Doctor, don't hesitate. We are in a radiology exam. If you
Okay.
ask the examiner to do MRI, he will not pay anything for the patient. He will give you the MRI. Okay?
Okay.
This
Okay.
is very easy. But before MRI, the patient did this one. What is this?
This is a nuclear study, a nuclear medicine study
Look here.
of the
This is the right. Compare with the left. This is the right. The right. 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 Do you remark any difference here from here? Hmm. There are any difference here from here?
yeah. There
What
is
happened?
uptake seen, increasing uptake seen in the right
Okay.
radial ulnar.
This is a blood flow, and then this is a blood pool, and this is one second, a delay. What is the name of this study?
Oh. Oh.
This is a bone scan, static or dynamic?
It's like a dynamic.
Yes,
Dynamic bone
excellent.
scan.
Yes, yes. We see in the arterial increased uptake in the distal radius. Check the blood pool. This is anterior. This is posterior. See, this is, where is the right? It should be, this is the right. This is the right here. Okay. Anyway,
Okay.
at least, I think this is, there are opposite, because this is the right and this is the posterior to be, this is the right. At least there are some discrepancy between right and left,
Yes.
correct? And then in the
Yes.
delayed, see, in the delayed, there are
Yeah.
also discrepancy.
Yes. Oh,
Okay. Which lesion in the bone take uptake, hyper uptake in the three phases, in the arterial, okay, in the blood pool, and in the delayed. Only two pathology.
only two
Tell me one.
pathology.
Tell me one of them.
Osteomyelitis.
Yes, excellent, excellent, excellent. Let's do another investigation. What do you want to do else?
Maybe the MRI that we mentioned just
Okay,
now.
this is the MRI, static image. What's your diagnosis?
In this MRI, I see increased uptake at the increase in
Intensity.
signal intensity
Okay, this is the
at
increase
the right.
intensity. Okay, and this is the post contrast. So what's your
Yeah,
diagnosis?
say there's a with the increase hyperintense as well as the surrounding tissue appears
Yes.
hyperintense with uptake enhancement. I would say this is osteomyelitis of the.
Thank you. Thank you, Dr. Suman.
Yes.
What happened here? This is X-ray from the beginning, really not conclusive. Ask for lateral.
Yes.
There are some at least irregularity or periostration. Ask for zooming. Ask for zooming. There are some here. This is not normal. Sclerosis, and I think this is lucency here. Okay, no extraosseous soft tissue. Okay, no cortical break here, but here I think there are this metaphysis is not a healthy metaphysis. There are some rarefaction or erosion. So they do a triphasic bone scan. When you see blood flow, blood pool, and the delay, this is a dynamic. Okay, here, see, this is the left, this is the right, as I told you. Okay, this is the left because this is posterior. This is posterior, so this is left, this is right. Okay, see if you see here, I don't know why here uptake is more than here. Anyway, there are discrepancy between here and here. I think this is right here and this is left, right, left, right, left. Okay, here anterior and posterior. I think this is the opposite. Why? Because here the uptake is less than here. Here is the most more uptake. more.
Yes.
Okay, more here, and here also the uptake is more. Okay, somebody can told me, doctor, no, this is the left side, and this is the epiphysis black. No, look at the epiphysis here, here,
Mm-hmm.
here. So this is not the epiphysis. Okay, there are intense uptake here. To my colleague, at least because I'm not I suspect about the direction right from left. At least there are some discrepancy. Okay, then after we doing this MRI, we find this expensive abnormal soft tissue edema and the bone marrow edema. So this is not a tumoral. Why? A tumor will be more localized. Okay, he may be associated with some edema, but not like this. Okay,
I see.
see the enhancement, markedly ill-defined enhancement. Okay, involving the bone marrow and soft tissue. This is the case of osteomyelitis. Thank you, doctor, so much. You did very well. Next,
Doctor, sorry, can
candidate.
I ask this now? Never mind.
Yes, yes.
Sorry, doctor, just now when you mentioned the two after the bone scan, a dynamic bone scan, there are two diagnoses. One is osteomyelitis. What would be
And
the
second,
other diagnosis?
tell me, tell me what is the second? Stress fracture.
don't know.
Stress fracture.
Sorry?
Stress
Oh,
fracture.
stress fracture.
The only two
Okay.
pathology that take that have hyper uptake in the three phases. Number one, osteomyelitis. Number two, stress fracture. Why? Because of increased number one, blood flow, and this is the responsible for uptake in the arterial. And number two, the osteoblastic activity in the osteoblastic is responsible for uptake in the delayed phase. Thank you so much. Do we have any
so
other
much.
candidate?
Yes, sir, at last 20.
Okay. Welcome, doctor. This is
Yes.
a 30-year-old female patient with abdominal pain.
Yes, sir. Sir, sir, I'm provided with ultrasound multiple images. I can appreciate there is in huge ascites. Both, so right ovary appears to be enlarged with large follicles. And also want to see other images. So right ovary appears enlarged. Left ovary also appears to be large. Both ovaries are significantly enlarged, bulky with dilated follicles. Both volume shows increased. Also want to see, sir. Okay, so both of these are enlarged. Other than this, there is ascites also noted.
What's your differential diagnosis?
And yes, sir, so there's a pleural effusion as well, so significant pleural effusion. So, sir, regarding age of the patient, young patient.
Yes, 30-year-old.
Okay, sir. Sir, in 30-year-old, multiple bilateral dilate, enlarged ovary with effusion. I'm suspecting that she may taken treatment regarding like hyperstimulation. Yes, because sir, in this age group, morely patient have this treatment.
Excellent. This is a hyperstimulation syndrome. Thank you so much, doctor. You did very well. And markedly enlarged bilateral ovaries associated with ascites and pleural effusion. Hyperstimulation syndrome. Thank you for all my colleagues. Study hard. Let's meet tomorrow at the same time for another session. Thank you so much.
Thank you so much, sir.